Hi everyone. Today I'm here with Dr. Ackerman, who is a PhD in nursing education, an RN, and a professor at a local nursing school. First of all, thank you, Dr. Ackerman, for accepting this interview. Just real quick, since I feel like even for me, there's a lot of confusion with what types of nurses there are and what each of those positions involves. Could you just kind of give us an overview of the different types of nurses and briefly what their roles are?
I would be happy to, and I think the reason that you're confused by it is because it's very confusing. So there are multiple ways that people can become a nurse. I think that the role of nurse that people think of the most is registered nurse. And there's multiple ways somebody can become a registered nurse, and it has to do with educational background. So there is the pipeline coming through the community college or the associate level. So that's usually like a 2-year program, not including prerequisites. And then there's the bachelor's degree, which is all of the undergraduate sorts of classes, the upper and lower division, GE requirements, and then the nursing curricula itself. This program is actually a MEPN program. It's a master's entry program in nursing. So students are simultaneously meeting the requirements for licensure and they're doing their graduate degree work. In order to get into a MEPN program, you need to already have a bachelor's degree in something. Other roles in nursing are nurse practitioner. And there are a couple routes to becoming a nurse practitioner, or let me change that. There's different educational levels of nurse practitioner. So a lot of nurse practitioners have a master's degree, but there has been momentum towards having nurse practitioners get a doctoral degree. So you'll see different programs out there and different levels of education around nurse practitioner. Another group of folks, healthcare providers that are nurses, are LVNs or LPNs, and they have more of a sort of a technical vocational approach to nursing where they're not doing the assessments and some of the other duties that are related to being a registered nurse. So we talked about associate, we talked about bachelor's, we talked about master's, nurse practitioner. So my degree, my highest degree, is a PhD in nursing. So that's more of a research focus, whereas the doctoral degree for a nurse practitioner is called a DNP, which has a clinical focus rather than a research focus.
Like, what led you to your particular field of nursing?
Yeah, I'm happy to share that. It's like one of those stories that from a young age, I definitely knew that I wanted to do healthcare. I like the human interaction piece of it. I like the sort of the pace and the intensity of it. In high school and early in college, I didn't know if I wanted to be a doctor or if I wanted to be a nurse. I was fairly open to both. The reason that I chose nursing over medicine is that I really wanted to have that liberal arts piece of it. I loved sociology and really the study of human interaction. I loved learning about human development across the lifespan, and I really liked the science classes, and nursing seemed like a great way to have both of those sorts of paradigms together. And just in talking with folks, it seemed like nurses did more of the day-to-day interaction with patients that just really appealed to me. Mm-hmm. So I got a bachelor's degree. I worked as an ER and an ICU nurse for many years. Began precepting students in the hospital setting, and just really, students, having folks that are excited about the things that are often mundane, like starting an IV or hanging an IV piggyback or something like that. Students get so excited about the opportunity to do that I was excited to do that, and that led me into the next phase, which is nursing education.
Okay, and since you talked about the differences between doctor and nurse a little bit, could you just elaborate that a little bit more? Like, what are the specific roles that nurses do and doctors do? Because a lot of people, I know people who I worked with who I was in undergrad with, who initially wanted to become a doctor, and then they ended up choosing nursing. Or I've even heard of people who started med school and they ended up becoming a nurse after.
Yeah.
So just kind of elaborate on that.
So the first thing that I really want to emphasize is that all aspects of the healthcare team are really vital and important part of patient care. So I think sometimes there becomes this rivalry and siloing between the professions, which I don't think is necessary. The role of the physician focuses a lot on diagnostics, like trying to figure out what's happening from a physiological standpoint and what sort of pharmacological interventions, surgical interventions, sort of medical interventions to provide to a patient. The nursing role is more of the day-to-day care where we're doing assessing not so much the diagnosing part, but carrying out some of the medical plan and building a relationship with the patient or the client so that we're able to understand who they are as an individual, as a family, and as a community. And let me just give you an interesting example of different approaches to healthcare. So this was a faculty development course, and we have both physicians and nurses in the class. And we had somebody come in to present a case. And so there's this case about the patient. There's all this information about socioeconomics and who this person was and is as an individual. And then it went into like the medications and the labs and stuff. So all the nurses in the room started with the beginning, like who is this person, and reading sort of the psychosocial background. And all the physicians instantly went to the back to look at the medications and the labs, right? And that just sort of illustrated the different approach. And it's not that one is better than the other. It's that we need both of those. And the two professions have different foci. And so when we can bring those together and work together as a team, that's when we really get high-end healthcare and better patient outcomes. And I'm talking about nursing and medicine. There are a lot of other folks that are very important to the healthcare team. Our respiratory therapists, our speech therapists, I mean, just on and on. And the better we can work together, respect and appreciate the roles that we do, the better the patient experience and the patient outcome is going to be.
Mm-hmm. What type of personalities are a good fit for nursing, would you say?
That's a hard question. And the way I'm going to approach that is that I think that most personalities have a place in healthcare. It's just that at some point you make a decision about what path you're going to do. And that path, it can be neither good nor bad. It's just that you will adapt to and you will grow sort of based on the philosophy of your profession. Mm-hmm. And we honestly need different types of thinkers in every single profession. You know, I think that if nursing has more of an emphasis on sort of human interaction, getting to know the person, if there's somebody that goes into medicine that has that tendency, that's a good thing. If we have people coming into nursing that are very pathophysiologically focused, that's also a good thing. That brings diversity into our individual professions. But in terms of health professions in general, I think that people need to be comfortable with human suffering on both a physiological level and a psychological level. We are seeing people at their most vulnerable. We're seeing people when they often don't have the internal resources to present in the way that they wanted to. Another example, I have a dear friend who is an ICU nurse, and she became very ill. She ended up having, I think it was bacterial meningitis, and she was out gardening when she sort of felt really poorly and ended up coming to the hospital. And as she's there, she was reflecting, I look terrible. I'm dirty. I'm in my worst clothes. I feel terrible. If people at the hospital didn't know me, they might think that I was something that I'm not, you know? And so we really need to have the ability to meet people where they are. So I don't know that there's a specific personality for the individual professions, but if you're going to get into healthcare, I think it's important that you have some people skills and that you care about people, that being a nurse or a doctor is more than a job and executing functions and tasks. It's about how you're making people feel, how you're inviting them into the healthcare system, how you're acknowledging them both as an individual and looking at the health conditions that they're presenting with.
How would you recommend someone who's maybe just graduating high school or is an undergrad, what would you recommend they do to get into nursing school or the different positions in nursing?
So there's sort of the quick path and the slow path. My path was a little slower. I come from a fairly poor background. I worked through school, and it took me a little while to figure out what I wanted to do. I think that if I had known earlier on that I wanted to be a nurse, that I could have saved some money and saved some time. But my path was my path, and I'm happy with that. Deciding early what you want to do. It's going to be really important, and this is hard for folks that are first getting into college, of taking your experience seriously. I've had several colleagues who did okay, like they were partying a little bit in college and getting C's and stuff, and those C's have come back to haunt them as they're having a hard time getting to maybe grad school or something like that. And nursing is very competitive now. I mean, we see a lot of applicants. Every single one of them have qualifications. They have pretty darn good grades. So how can you be competitive with that? Keeping your grades up. Outside healthcare experiences are very helpful. Working as a certified nurse assistant was the route that I took. And that was so helpful. I mean, I came into nursing school with a pretty good comfort level interacting with folks in the hospital. That was no problem for me. Volunteer experiences, and the more healthcare related, the better. Don't compete with other people. You know, everybody's process is their own. Like I said, I took a longer path. I'm still here. I'm a successful nurse. Some people do it really quickly. I think when you start comparing yourself to others, it can be demoralizing. Mm-hmm. The cost is no joke. You know, I really plan ahead for student loans or financial aid. And what was the other? I had another pearl, but I forgot it for a moment. Can we come back to it if I think of it?
CRNAs or NPs, like a lot of them are, like the role between the physician and the nurse is kind of like get more grayed out, right? So they're kind of like be almost like physicians in a lot of those regards. So could you just kind of explain kind of how that process is going? It seems like there's a more and more push for more like autonomy in those kind of specialties.
Yes, and I didn't bring up the nurse anesthetist when we talked earlier, and I think that's a good example of some of those blurred lines. And honestly, the lines are fairly blurred with healthcare, and there are turf wars that are happening. And so in 2010, the Institute of Medicine came up with the Future of Nursing report. And one of the key items that was in there, one of the key messages was that nurses should work to the full scope of their practice. And what we know is that a lot of nurses are able to do far more than the hospital or the agency allows them to do. And it varies state by state, particularly with nurse practitioners. So even though California is very liberal in some ways, we're behind the curve with autonomy related to the role of a nurse practitioner. And you'll see that there's a lot of political momentum as nurses are trying to say, we want to work to the full extent of the scope of our practice. And my view of this is fairly nurse-centric, but it seems like physicians are sort of pushing back on that. I mean, there are terms that are fairly derogatory, like referring to a nurse practitioner as a mid-level. So what does that mean? That a physician is a high level and that what a registered nurse is a low level? Like you start to do this hierarchy thing rather than looking at the potential for sort of this team-based approach to healthcare. That said, there are a lot of physicians that are very supportive of, you know, the full extent of scope of practice for nurses. But it seems like the the AMA is pushing back, saying no, physicians should still have the last say, and we should be overseeing, the medications that are being prescribed and stuff like that. So I think we have some work to do. I think that it is blurry and varies from location to location, but I feel confident that physicians are hugely overworked. There are not enough primary care physicians, and those that are in practice work so very hard. And here is this entire pipeline of folks that can help fill that need. So at some point there's going to be a tipping point, and we're gonna move forward. And if you look historically, some of the stuff that we take for granted as nursing work was physician-only work. Take doing a blood pressure. That was something that physicians did. That was an intervention. And now it's mostly nurses and CNAs that do that. IV starts were considered an invasive procedure that only physicians do. And it's been a long time since I've seen a physician start an IV. That's usually something that nurses do. So there's sort of this steady progression that happens over time. And I don't think any of us need to be worried about losing anything. There is plenty of work in the healthcare system. There's plenty of room for all of us.
Could you kind of walk us through a typical day in the life of a nurse?
Yeah, I think if it's okay, I'd prefer to use the lens that I have, which is being an ICU nurse. The majority of ICU nurses work 12-hour shifts, and you'll find that we want that. There is probably a strong argument for the value of 8-hour shifts in terms of how exhausted you get, especially at the high pace and the intensity of the acute care setting. But nurses really like their days off. It was very convenient when I was a staff nurse doing 2 or 3 12-hour shifts a week. Especially having small children at that time, that was very convenient. I didn't want to give my days off up. So it's a long shift, and you work hard. In the morning, you would come in, things get rolling really quickly. You would come in, you would assess patients. So you would come on to shift in the morning, things get going pretty quickly. I work day shift, and the day shift is fast. Not to say that the night shift isn't, but they're just two different sorts of things. But you would have lots of things that were happening immediately. You need to get report. You need to do your full body assessments on both of your patients. You would have medications to give, blood sugars to check, and usually there's a whole line of a medical and a nursing plan that needs to be implemented. So you're helping with procedures, you're managing drips and medications, you're keeping the patient clean. In the ICU, there's a lot of invasive apparatus. Think of somebody on an endotracheal tube, and this is a tube that goes from the outside of one's body into your internal organs, into your lungs. And you've just created this beautiful bridge for all kinds of what I like to call buggy bugs to crawl down, right? So a lot of the job is infection prevention. So with that ET tube, you need to keep all of that area clean. You need to make sure that you're doing good oral care. You need to make sure that you're turning the patient so they're not at higher risk for ventilator-associated pneumonia and consolidation and those kinds of things. We do assessments, every hour to 2 hours unless the patient needs that more often. So you end up running a lot, and then there's the interaction that's happening with the team. You have different physicians that are coming in with different specialties. You have your physical therapist, speech therapists, and so the role of the RN is to coordinate all of that care and make sure that the patient is getting what they need and that the communication is happening. There's a lot of communication that happens with the family, which I really loved that part of talking over what's happening with the patient in a way that's both scientific and understandable, and being upfront about what we know about potential outcomes and what we don't know. So there's a lot of teaching that would happen. But I have to say that towards the end of the day, you're tired. Feet hurt. Your head hurts, you want something good to eat. So yeah, it can be long, but I don't know, I've never had any regrets, and I don't work as an ICU nurse now, and honestly I miss it. I miss it a lot.
Okay, and is that experience comparable to other?
Yeah. So even though I think of ER nursing and ICU nursing as two different ends of the spectrum, ER nurses are running all day long, patient to patient to patient, and just almost this sensory overload from having so much information coming in. There are nurses that work on the medical surgical units and sort of different specialties of medical surgical units. They work really hard but have the same sort of schedule of coming in and doing assessments and medications and doing interventions all day long. I don't know as much about labor and delivery. I think that is a setting where there's just a lot of up and down. I mean, it really depends on what the moms are doing and where they are in their progression with their labor and delivery. But nurses work hard. I mean, you were asking earlier about personalities. You have to be a hard worker and be able to deal with different levels of, physical discomfort, a certain amount of gray area. I mean, people always want to know, like, what's the right answer and what's the next thing to do? And really what you're doing is you're using your higher cognitive skills to make really difficult decisions. And you're in that space a lot. And a lot of times there's ethical values that are completely clashing and that you're not able to resolve. I mean, no matter what step you take, there's sort of a negative ethical implication for that. And you have to be comfortable with that.
And so you mentioned different departments. How easy is it? Because like for physicians, you have to do a whole residency, right?
Yeah.
You have to do different residencies for nursing, or?
It's different than with physicians. Yeah, physicians specialize and tend to stay in that specialty. In nursing, there is a lot more room to move around. There is a perception that nurses should start on a medical surgical floor, and there's a little bit of foundation for that. You get to see a wide variety of patients. There are a lot of tasks and skills that you do, so it's a great setting, but you don't have to start there. We certainly have new graduate nurses that go directly into ICU nursing or ED nursing, but you can switch. And I would say that it's probably easiest to go back and forth between ED and ICU and maybe med surg as well. There are aspects of nursing that are quite different. Like, for me to go into labor and delivery, I would need quite a bit of catch up. I haven't really done anything around labor and delivery, and it's kind of its own specialty. Not kind of, it is its own specialty. There's mental health nursing. That would be sort of a lift for me to relearn that and become specialized in it. But I could definitely do that in the span of a career. And that's one of the things that draws people to nursing, is you're not making a lifetime commitment to one specialty. You can move around, and I've had the luxury of that, and for me that's been great. There's always room for growth and to try something new, and there are nurses that find their specialty and they stay there all their career, and that's also totally possible. So yeah, it's different in that way than being a physician.
Yeah, I heard similar with like PAs, they're able to like transition to different specialties, and it's kind of nice. I wish physicians could do that more.
yeah, you make a big commitment at some point.
And I've heard of people doing multiple residencies, but it's kind of a pain.
Yeah, and med school and residency is so long anyway that adding on to that, I mean, I can see folks wanting to have their life back at some point and to move on. So yeah.
Okay, so could you mention the most rewarding and most challenging aspects of nursing?
So back to sort of a personal philosophy. I feel like some of the most magical moments that happen are in the life spectrum. I mean, really the two most important things that happen to humans is that they're born and they die, right? And being part of either ends of that spectrum seems magical to me. And I said I didn't work in labor and delivery, but I've spent time in labor and delivery. And when a baby is born, it's like there's this magic and there's this hope that is just in the air. And I feel so honored to be part of that process. And I have a really similar feeling when somebody dies. I mean, that's a significant transition, and it's hugely meaningful for family members in numerous ways. And having that transition be as positive as it possibly can be, I don't know, it feels magical to me to be part of people's lives with that. So I feel like it's an honor. And then there's everything in between, you know, all of those amazing things that happened. The guy that fell off a cliff, and he was so neurologically damaged that we didn't think he was going to make it. But he did. You know, he was with us for months. He ended up going to rehab. And I remember it was on Christmas Eve. He came into the hospital. He came into the ICU, and we're like, can we help you? And he's like, it's me. And we're like, no way. You know, this beautiful, robust human being who had survived this thing. That was another moment that gave me chills. Like, we had made this sort of, this impact, you know. I would say those are the great things. The flip side of all of that is that it is intensely emotionally draining. And in some ways, there are things that are being taken out of your bucket. And if you're not having some mechanism for having your bucket filled, you can become very burnt out and jaded. For me, I like that human interaction part. I like what might be called the touchy-feely sort of, you know, that part fills my bucket and makes it worthwhile for me. If somebody's not getting that, or there's been too much of a withdrawal and not enough of a deposit, it feels pretty painful. I just remember feeling so physically and psychologically drained sometimes, and it was hard to have faith that you would come back to that feeling of hope and inspiration and happiness. But for me, it always did come back. I think that integrity has a big piece of that. Of, you know, you don't know if you're making the right decision, but trying to make the best possible decision for patients and families, and having it not be all about you, feels good at the end of the day, even though it's sometimes hard to make those sacrifices. Mm-hmm. There's also, you know, I love the human interaction part, but that sometimes can be difficult as well. I mean, you are dependent on a team, and if that team is not working well for whatever reason, mm-hmm. it's very challenging. Mm-hmm. Whether it is discord that's happening between nurses, or between nurses and physicians, or even between physicians, that part I didn't like. Mm-hmm. The sort of the politics and the struggling for maybe power, or that kind of thing was hard for me, for sure.
Okay, so with that, like, you also kind of mentioned how with that there's kind of like some divide between the different kind of healthcare professionals. Mm-hmm. in like a healthcare setting. Sometimes like physicians or other healthcare professionals consider certain types of nurses as like mid-levels or things like that. Mm-hmm. What other misconceptions are there? I
think that all of us as healthcare professionals would benefit from having the education, and if you weren't given it in school, seeking the information about what it is that your colleagues do. I think a lot of times physicians don't entirely understand what nurses do. I think nurses don't always understand the perspective of a physician. I remember a physician talking to me about being called at 3 a.m. and being woken up, and when the nurse says, doesn't say the patient name or the diagnosis, and just sort of is spitting out all of this stuff, and they're like, oh, hold on, I just woke up, let me catch up. Yeah. That was sort of life-changing for me, like, oh, wow, yeah, I unfortunately never took the time to think about what that call is like for you, and understanding that helped me change the kind of care that I'm giving. Yeah, the S-bar. I mean, the S-bar has been really great, and there are times when I was not good at S-bar. I just call and say, the person in 110 needs a Tylenol, or, the person in 110 has a fever. What do you want me to do? And they're like, okay, who's 110, and why do they have a fever? What are the other things? Or, having that phone call and they say, what's the temperature? And I'm like, let me go check, come back. Well, what's the blood pressure? Hang on, let me go check. Like this idea of gathering things together. So that was helpful for me to understand. I think that physicians don't always understand the level of education that nurses do have, that we have really intense classes around pathophysiology and pharmacology, and our understanding is a lot greater than physicians know about. How we have a focus on things like nutrition and, psychosocial sort of wellness, and that's really our emphasis. I think when physicians understand that, they realize, wow, that's beneficial to me. That makes my life easier when that happens. So I really think that we would benefit from knowing more about each other. And honestly, when you are overworked, which every single healthcare provider is overworked, the easy thing is to silo and make your world more containable and therefore easier to navigate. Like if I look at this much, it's a lot easier than seeing the bigger picture. And we kind of default to that under stress. And we really need to mitigate that as much as we can so that we're still giving the kind of care that we're capable of.
How are different types of nurses compensated, like generally, like the salary ranges and kind of?
Yeah, I think a lot of it is perspective. I told you earlier that I come from a very poor background, grew up with welfare and those sorts of things. So when I got my first check as a nurse, I was just like, this is so much money. I am so happy. My first move was to go to Costco and buy the fanciest toaster that I could possibly find. I had some old toaster that probably came from a thrift store, so that felt like a lot of money. And I'm in a socioeconomic class that I didn't grow up in. And so I feel like I have a great salary and a great lifestyle. Do I make as much as physicians? Certainly not. But I make a very good middle class wage. Within nursing, there are different fields that make more or less money. I'm in the lowest paid of nursing specialties, which is education. And, educators just don't get compensated as much. So working as a staff nurse is good paying, especially in the state of California. I mean, salaries are, somewhere around $50 and $60 an hour. If you're doing a specialty like OR nursing, or if you're a cath lab nurse, you're expected to do on-call. So if you're called in, you're getting time and 3/4, and that adds up. So you can be, making a pretty good wage, somewhere between $150,000 $200,000 a year with that. Nurse anesthetists make really good money. Part of it is because of the income that's coming into the hospital and what they can be reimbursed for, and also that sort of overtime that they make as well. So yeah, I mean, if you're in it for the money in healthcare, being a physician will probably give you more pay over time. And that overtime thing is important. Physicians have student loans, and there's this whole time of residency where nurses are making more than residents, and that piece is hard. But once you get past that, you'll make more money. I think nurses are able to make more money sooner.
So since you do research, what kind of opportunities are there besides clinical clinical practice for nurses? So
one of the things that, like, when people ask me what I do, I feel like I have a nice balance. I'm a nurse, I'm a nurse educator, and I'm a nurse researcher. And I've found a position where I'm able to do all of those things, which is really great. So I am a professor, and a certain amount of my time is dedicated to a bucket that we call scholarship. And within that, there's a certain amount of research. So the research I do is around our health professions pipeline. We know that there are long-lasting and significant health disparities in the U.S., and it is very clear that there's a socioeconomic component, there's a racial component. People from the LGBT community experience a lot of health disparities, women, children, and the literature and the science around that is robust. So one of the ways that we can begin to promote health equity, so that's mitigating health disparities with evidence-based solutions, is by having a diverse healthcare pipeline. So a lot of my research is how do we recruit more students of color and students with different diversity backgrounds into the health professions. And once they get into our schools of medicine and schools of nursing, how do we make sure that they feel included so that we're not asking our students of color or our first generation or low income students to survive our programs, but we're actually looking at strategies to help them thrive and meet their full academic potential. So in order to do that, I do research on student experiences in school. What are their experiences of inclusion? Who are the people that are inclusive? How does that look? And then conversely, what are the experiences of exclusion? Who are the sources? What does that look like? And then doing faculty development around how we can create learning environments that allow people to be authentically who they are and bring the value of their diversity into the healthcare workforce. And I feel blessed to be able to do that, to be able to teach students and also have my fingers in what is clinically relevant and new and fascinating.
Did you have to have a PhD to do that, or could any nurse do that?
So the education piece, let's talk about that first. There are different levels that nurses can work as educators. So at the associate level at community colleges, if I remember, the criteria is that if you have an associate degree, you have to have, I think it's 4 to 6 years of nursing experience to teach. If you have a BSN, you need to have about 1 year experience. They love to have masters prepared and PhD prepared. At the baccalaureate level, you need to have a baccalaureate level nursing degree to teach clinical. If you have a master's degree, there's the opportunity to teach clinical and some theory-based teaching. And then if you want to get on a tenure track, you need to have a PhD. At universities, like in the UC system, in order to teach in the theory classes, you need to have a PhD. And the folks that are teaching the clinical, like taking students into the hospital, need to have at least a master's degree to do that. Oh, and then so you're asking about research. So there are different levels of research. And one of the ways that I break it down and explain it to people is that research for BSN prepared, we really want nurses at the baccalaureate level to know how to consume research so that they can conduct evidence-based practice. At the master's level, it's more the ability to consume and critique, like really understand what makes good research and whether it's sound or not. At the PhD level, you need to be able to consume, critique, and conduct research. So those are sort of the different layers of interaction with nursing research.
Kind of going back to something you talked about earlier of how one of the biggest challenges about nursing is that it could be emotionally taxing. So how do you recommend nurses or just healthcare professionals in general deal with burnout and establish that work-life balance, since you said you have 2 kids and you like the shift work?
I do. I actually have 4 kids. I might have just mentioned 2. So yeah, that's been challenging, and I don't know that I have achieved that work-life balance. I mean, I definitely have found myself physically out of whack, with the back injuries and, just that chronic exhaustion. And so the challenges are when you're working 12-hour shifts, eating well and sleeping well, and then fitting in exercise. I mean, that has been a huge challenge. I have struggled with, my role as a nurse and my role as a mom, that those things should come first and that my healthcare needs, my physical exercise and stuff is secondary. And I've paid for that over time. I mean, I just feel like I've paid for that with the aches and pains and sort of things that I grapple with now. And if I could talk to my younger self, I would say prioritize yourself, because you're in it for the long haul. I mean, my kids are older now, but they still need me to be at my best, and your body can only take so much from a physical standpoint. So really prioritizing and allowing yourself to have that restorative time. For the emotional component, one of the things that is really helpful is when things are hard, and they will get hard. And, an example is working with a patient. Sometimes we have patients who I can't describe otherwise than being broken. People that have these horrific things that have happened in their lives, and their coping mechanisms are things that are stigmatized. Maybe it's obesity, or maybe it's some form of substance addiction. And, folks come in, you're irritated with them. They're very demanding. They often don't interact in a way that we expect them to, the social interaction. An example is a patient that we had that had an opioid addiction, and she would drop F-bombs all over the place. I mean, every other word was a cuss word, and people were getting offended by her, like, she's so aggressive. And it's like, that's not the biggest deal. I mean, how can you expect this person who has been through so much to adhere to your expectations of what social interaction should look like? Nevertheless, it gets overwhelming after a while. Like after a 12-hour shift of somebody on their call light, on their call light, on their call light. And it's like, I have other patients, I have found myself at the end of shift, like, I can't wait to get home. And I feel like I have a certain amount of compassion. And at the end of the day, I'm at the very end of I'm digging deep there to find the compassion. But a couple things bring me back around. One is why I came into nursing. That remains strong, is my commitment to service for others. And then realizing, with that particular patient, I remember driving home and thinking, she's still in the hospital. Her life is still broken. What am I going to do? I'm going to go home. I'm going to have a nice meal. I can sit down on my beautiful couch and watch TV or read a book, or, I'm going home to a life of pretty good privilege, and sort of appreciating that is what would bring me back around. And, yep, I'm in for another 12-hour shift, but it's only 12 hours and I get to go home back to my beautiful life, my beautiful kids and my beautiful family. So that's what's worked for me.
The improv is poetic. Okay, so last question. How would you recommend people, or either nurses or nursing students who want to become nurses, or just healthcare professionals in general, become a good healthcare professional?
I think it comes back to some of the things that we have talked about already, which is maintaining the values that made you want to become a healthcare provider. And something happens in the educational process. And medicine, I understand something happens between like year 2 and year 3 where, med students are very idealistic and they have these values, and then they sort of hit the clinical setting and something changes. It's like there's this culture that is out there, and sometimes this idea of giving this great patient care and being so patient-centered is swimming against the current, and hanging on to that, having the integrity to say, no, I'm not going to go with the culture of mistreating and judging and stigmatizing people. That's not how I roll. There's a certain amount of integrity that comes with that. And if you can hang on to that, I think that we become change agents and we reshape the way that healthcare looks. And we have evolved over time. We have the potential to do that. And I think that we're happier when we maintain the values that brought us into healthcare, and when the healthcare provider is happy and in alignment with their own values and how they want to treat people, then they're able to treat people that way. It's when you become jaded and exhausted and succumb to sort of, there's like this culture of despair that sometimes exists in the healthcare system. So protecting yourself from that, having a good support system outside. I think it's good to have colleagues in the health professions where you can really talk about some of the stuff. I mean, people that aren't in health professions don't quite get it. The talking about a code brown over a spaghetti dinner, that's no big deal in my house because, my husband is also in healthcare and that doesn't bother us. But if I were married to somebody that's like, "Ooh, don't talk about that over dinner," I'd be like, "Oh, this is like adding another layer of stress," So I'm not saying marry somebody in health professions, but have a support group from your profession.
Great. Well, thank you again so much, Dr. Ackerman, for
my pleasure.
spending this time with us. And thank you guys for watching. Let me know down below in the comments who you'd like me to interview next. And let me know also in the comments if you have any questions about nursing. I could ask Dr. Ackerman and relay it back to you guys.